Thank you all again for having me again. I'm Thomas Marsden, one of the thoracic surgeons at Our Lady of the Lake. I'll be talking today, again, about lung cancer screening, but we'll start with lung nodules, lung cancer, and then lung cancer screening. To give a full and detailed talk on this topic, it would take days to weeks of lecture. So I'm going to try to hit the high points, but again, if y'all have any questions during or after, please feel free to ask. So to start, what is a lung nodule? Some people call them spots, some people call them shadows on the lung. These are three different definitions from three different societies around the country. The top one, the STS Society, it's an area of the lung that's more dense than the surrounding tissue. One of these other ones is a small growth in the lung or a small abnormality in the lung. But in the grand scheme of things, what is a lung nodule? It's something in your lung that shouldn't be there, okay? That doesn't always mean it's necessarily bad. Quick, some pictures. These are CT scans. I will say, in the last session, someone asked about chest X-rays for lung nodules and lung cancer. That was part of the screening program in the past. It was found not to be as effective as CT scans. So the CT scans, I'm getting a little ahead of myself, but the CT scans now are the main imaging modality to detect lung nodules. Again, a CT scan, real quick, is a image. I tell patients when I see them in clinic, it's like we cut you like a loaf of bread up and down, and we look at each slice to see what's in that slice. It's reversed because you're looking at yourself from the feet up, so the left side of the screen is your right side of the body, and the right side of the screen is your left. But you can see here's a little lung nodule that's probably 2.5 centimeters. This is probably a 1 centimeter lung nodule in the right upper lobe. They're described, again, you're trying to turn a three-dimensional shape into a two-dimensional picture on a CT scan. So we describe them as coin-shaped lesions. They're not always, some are more oblong, dumbbell, but more or less they're coin-shaped lesions. And as a little aside, if I had to argue, most humans throughout their life, at some point, lung nodules can come and go as well, but most humans will have a lung nodule at some point in their life. That's how common they are. And again, looking at this slide, out of all the lung nodules that we see and that we investigate, we get biopsies from, less than 5% are actually cancer. Now, but when you think of that number, if most people have a lung nodule at some point in their life, that 5% is a fairly big number still. Now, what are the three main categories for lung nodules? The three main ones I tell people, and this is very broad, but are infection, inflammatory, and malignancy or cancer. Those are the three main things that can cause lung nodules. Infection and inflammation kind of go together because infection does cause inflammation, but from an infection standpoint, pneumonias, healing pneumonias can cause scar tissue that when they scar down can look like nodules in the lung. Again, no risk of cancer, but it looks like a nodule, and it's hard to differentiate a benign versus malignant lesion on imaging. There's one common, I trained actually at University of Kentucky in Lexington, but it's down here too. There's a fungus in the soil that's ubiquitous. It's everywhere, called histoplasmosis, that is notorious for causing nodules in the lungs that are very hard to differentiate from lung cancer. Most people develop no symptoms from it. If anything, it's a mild cold, less than the flu. But if you get a CT scan 20 years later, you'll see a lung nodule. My dad has one from histo, and they followed it, ended up, again, being benign. From an inflammatory cause, people with rheumatoid arthritis or sarcoidosis, those are two of the more inflammatory autoimmune diseases that can cause lung nodules to be present. Again, those aren't no risk of being cancer, but again, they're difficult to differentiate, especially on one scan if you don't have serial scans to follow them. Now, why should we worry about lung nodules? Again, we talked about the 5%, even though that's a big number. Well, that risk does go up if you have certain risk factors, of course. These are some of the most common ones. Some are modifiable, some aren't. Some of the non-modifiable ones are older age and family history. Again, you can't slow down time. We're all getting older. And from a family history, you can't pick your parents, you can't pick your genes. Some people are genetically susceptible to certain diseases more than others, just from their DNA. The one big modifiable one on this list is tobacco use. And as a little side, this presentation is not, I'm always going to promote smoking cessation. That's not what this topic's about, but as some aside here, the prevalence of smoking still in America in 2022, this was the most recent data, almost 20% of people still use some form of tobacco product, whether that's cigarettes, cigars, e-cigarettes, dip or snuff. From a combustible standpoint, it's closer to 15%, and in this column, we mainly focus on cigarette use. It's hard to quantify for us when I get to the screening guidelines, the e-cigarettes or vaping, and how you can calculate that for a lung cancer screening. But from 11.6% of people in America still smoke cigarettes. In Louisiana, that's 15.7%. That's the third worst in the country, behind Kentucky and West Virginia. I think West Virginia is up to 22%, so they have a lot of work to do up there, but we're still not far behind. So again, not what this topic's about, but I always promote, not just from a lung cancer screening, but heart health as well. Smoking has a lot of side effects. So again, why worry about lung nodules? The difficult thing with lung cancer is it doesn't develop symptoms until it's at an advanced stage. So it can be hard to detect. One, it's hard to detect. Two, we haven't historically had a good way to detect them. It doesn't cause symptoms until it's at an advanced stage. And once it's at an advanced stage, it's hard to manage or treat. Some of the symptoms from lung cancer when you do have them, chest pain, hemoptysis or coughing up blood, weight loss, night sweats, chills. Again, some of those you can have with several different types of cancers, but by the time, if it's from a lung cancer, it's usually at an advanced stage 3 or stage 4 level where it's much harder to manage. Looking at some of the statistical numbers, in 2023, and this has been steady over the past 10 years, but there's about a little over 200,000 new cases of lung cancer diagnosed every year, and approximately 130,000 deaths per year from lung cancer. Now that makes lung cancer the leading cause of cancer-related death in the United States. That's more than breast, colon, and prostate cancer combined, which when you think that's a large number of patients from a lung cancer. So I bet everyone in this room probably knows someone that's had lung cancer. Maybe not a direct relative, friend, friend of a friend. Going along with not developing symptoms until it's at an advanced stage, the 5-year survival for all comers for lung cancer is 27%. So if you think about it, if 4 people are diagnosed with lung cancer, only 1 patient over a 5-year period is still going to be alive. That is an abysmal number. That is very low. We have a lot of work to do. There's been a lot of advancements in lung cancer, lung cancer screening and lung cancer management, but that number is low. When you break that number down, though, into the different stages, like we talked about, with stage 1 being the earliest stage, easier to treat, with stage 4 being spread, metastatic, more advanced stage, the survivals are drastically different. So stage 1 lung cancer, the survival's anywhere from 75 to 95%. But for stage 4 lung cancer, the 5-year survival is 0 to 10%. So that shows you that there's a huge range in survival. But if we can do something to detect them earlier, that would give you, 1, we have more management options, 2, decrease your the complications or the risk from the cancer or the treatment option, and improve survival. So with that being said, early detection is key. Now you may ask, how would you detect the lung cancer? Historically, it was chest X-rays. Now chest X-rays, I actually don't have one pulled up here, but chest X-rays are much harder to detect lung nodules than CT scans. You can't see the whole area of the lung. Some of them aren't radio opaque on chest X-rays where you can see them. So that was actually abandoned. The chest X-rays did not improve survival from a lung cancer standpoint. But when you look at the CT scans and what I'll talk about, it has drastically changed, and that was as of 2013. So the main group, there's different societies, there's 4 or 5, which kind of muddies the water from a lung cancer screening standpoint, but there's 4 or 5 different societies. I would argue this is the most prevalent, important one. It's the United States Preventive Services Task Force. This group not only does lung cancer, it does all sorts of preventative medicine, high blood pressure, overweight, different, colonoscopies, mammograms, vaccine schedules for kids. They make recommendations. It's an expert panel for whatever topic they're talking about, and they make these recommendations. So in 2013, they made their first lung cancer screening guidelines. And as an aside, there's been a lot of research behind colon cancer, breast cancer, prostate cancer, and I'm not trying to say anything bad about those cancers. There's been a lag with lung cancer research historically because people always used to say that it was related to smoking. You did it to yourself. That it is what it is. That's not fair. That's wrong. I'm not saying I agree with it, but that's kind of the history of how lung cancer was thought. There's been especially in the past 10 years, but really the past 5 years, an extraordinary amount of research going into lung cancer, and a lot of that is has to do with the lung cancer screening. So in 2013, again, they made their first guidelines for lung cancer screening. This recommendation is updated as of 2024. And these recommendations are, if you're age 50 to 80, if you currently smoke or have quit within the past 15 years, and you have a 20-pack year history. we calculate pack year history based off how many packs of cigarettes you smoke a day and how many years you smoke. So if you smoke one pack of cigarettes a day for 20 years, you have a 20 pack year history. If you smoke half a pack a day for 20 years, it's a 10-year history. Or if you smoke two packs a day for 20 years, it's a 40 pack year history. The original guidelines were actually 30 pack years, but they've decreased as of the last year to include more people. If you meet these three criteria, you qualify for an annual or yearly low-dose CT scan of the chest to detect these lung nodules, and you can have them every year. It is covered by Medicare, Medicaid, and almost all private insurances. I say that. I've never had a problem in Louisiana with any private insurances getting people covered for the low-dose CT scan. I've heard horror stories in other states of people not qualifying. Even though they meet these guidelines, they don't qualify for their insurance. That's why I didn't put all private insurances. But from a Louisiana standpoint, I've never had any problem with that. Now, if you're going to recommend something, especially a screening, you have to show that there's benefit to it, right? You don't want to just do CT scans of everyone's chest, and it's not going to change the outcome, especially from a lung cancer standpoint. The outcomes actually are fairly drastic, especially when you look at this chart, but it's resulted in more or less of a complete stage shift in lung cancer. If you look at this chart, and this goes from 2016 to 2019, so the years are a little outdated, but the data collection lags behind a little bit. So in 2006, advanced stage or stage 3 or 4 lung cancer, the more advanced lung cancer stages, 70%, when people were first diagnosed with lung cancer, 70% were at advanced stage versus about 20% that were at an early stage. When you look at 2019, there was 62% were diagnosed at an early stage versus 30% that were diagnosed at an advanced stage. And if you look, that inflection point is right at about 2013, 2014, where lung cancer screening was started. So once lung cancer screening started, it's changed completely from most people being diagnosed at an advanced stage to most people being diagnosed at an early stage. And that's drastically changed how we can manage lung cancer. We usually manage it, there's 3 main modalities, surgery, chemotherapy, radiation. If you're diagnosed at a stage 1 disease, we can take it out surgically. If you're not a surgical candidate, you can do radiation, will not need chemotherapy. There's an abundant more options than if you're at advanced stage, which is more chemotherapy or immunotherapy related. Yes, sir.
And that screening that happened about that time was CT?
Yes. The chest x-rays, I believe, were in the 80s to early 90s, and they actually abandoned that. So there was then a period where there was no recommendations for lung cancer screening. With that being said, I just remembered some of my next information is from actually Thursday, this past Thursday. But in the Baton Rouge area, just from our Lady of the Lake lung cancer screening program, we have a whole group that comes together. We're on pace to screen between 2,800 and 3,000 patients this year. So we're on pace to do quite a bit. And that numbers, when we started our program in 2018, I wasn't here yet, but my partner, Dr. Cassidy, it's drastic. We've significantly increased the number of screeners. So like I said, with detecting lung cancers at an early stage, it leads to more treatment options, decreased morbidity, decreased complications, not only 1 from the cancer, but 2 from the treatment options, and improved survival, as you can see. I'll show you on the next slide. The unfortunate thing is I don't think lung cancer screening is that prevalent. A lot of people don't know about it, not just the community, but the medical field as well. We go and advertise to primary care clinics all around, and they have no clue about it. Nothing against them. It's just this isn't as advertised as much. Because if you look at this number in 2022, in 2023, I think it was 15%, so I actually think it was 1% lower. Of all people that qualify for lung cancer screening, only 16% of people received it. So that number is very low, especially when you compare, from a breast cancer standpoint, people receiving mammograms, or colon cancer, people receiving colonoscopies. Those numbers are closer to 50 to 60%. So again, we can do a better job at advertising and making this known that lung cancer screening is a modality. This is my last slide, and this is the one that hits closer to home. So this is in the Baton Rouge area, specifically at Our Lady of the Lake, the lung nodule screening program. So from 2018 to 2022, 44% of patients were diagnosed at an advanced stage versus 29% that were at an early stage. This information, again, is from this Thursday. This past Thursday, we have every quarter we have a meeting that shows us our data. And this year so far, out of stage 1 cancer, 60% are diagnosed at stage 1 versus 9% that are diagnosed at stage 4. So from a lung cancer screening standpoint, it's drastically changed it. It's improved the survival. The 5-year survival, again, from a stage 1 lung cancer, 70 to 90, 95%. From a stage 4, 0 to 10%. So again, a drastic benefit and drastic stage change, not just from the lung cancer screening program. So here are some of my key points, the conclusion, but really I think the important part of this talk is just getting the information out there, letting people know that lung cancer screening is a thing, not just from the community, but from the medical field as well. So if y'all have any friends, families, friends of friends that are heavy smokers, just let them know about it. It's a non-invasive test. It's a CT scan. They run you through the scanner. It's not as invasive as a colonoscopy. No one in here should be getting mammograms, but it's a non-invasive test, quick, and we can see in our clinic if there's any abnormality on it. So if y'all have any questions, feel free to ask. If not, we can take questions afterward. All right, I'll pass it on. Thank y'all very much again.
Thank you. All right, thanks, Dr. Marsden. Let's see, I'm on here, yep. So I'm James Barrios. I'm one of the clinical cardiac electrophysiologists at Our Lady of the Lake Physician Group and with Louisiana Cardiology Associates. Thank you all for having me, and I'm here to talk to you about irregular heart rhythms. And in particular, at the end, I'll focus on the most common one called atrial fibrillation that many of you have heard of or might even have. But we'll talk about the kind of whole gamut. Like Dr. Marsden said, it's almost easier to put together a 6-hour talk about irregular heart rhythms than it is to do a 15-minute talk, but we'll try to get through it quickly. So arrhythmia, just meaning an abnormality in the way the heart beats. The heart's a muscle, a lot like the other muscles in the body, but it's obviously finely tuned to pump blood throughout the body. But maybe what's a little less known or understood in the general population is that it's a really fine-tuned electrical piece of equipment as well. We all have this thing called the SA node, or most of us, that kind of tells our heart to beat. It's our kind of inborn pacemaker, so to speak. That sends signals throughout the top chambers of the heart that are called atria. And it meets in a gatekeeper between the top and bottom chambers of the heart called the AV node. And that sends off 2 big electrical wires to the left and right ventricles that are the bottom chambers of the heart. So when everything is beating well, everything is going normally, this is what the electrical system of the heart looks like. But sometimes the heart can beat too fast or too slow, tachycardia or bradycardia, and in those specific situations, we have to think about why it's happening and different ways that we can treat it to help prevent the morbidity and mortality from these abnormal heart rhythm issues. So this is a normal EKG. This is what hopefully everyone's EKG in this room looks like. But if you have any abnormal heart rhythms, this is kind of the mainstay of an electrophysiologist. This is what you'll get when you come in to see me in the office. We'll talk about this. We'll assess any abnormalities that might be there. Or even if it's normal in the office, we'll talk about abnormalities that could be present depending on what kind of symptoms that you're having. This is kind of a whirlwind through bradycardia or a slow heartbeat. These first 3 are either normal or benign findings. So not every skipped heartbeat requires aggressive therapy. A lot of times skipped heartbeats can just be monitored closely. But depending on the level of the skip and how frequently they happen or how severe they are, then if you get into things like down here, something called 3rd-degree heart block or complete heart block, that's when the top and bottom chambers of the heart are not communicating at all. That's when we talk about, gosh, you need a pacemaker, and we need to make sure you're not skipping any heartbeats. And this is what pacemakers look like. That's not the point of this talk. We'll talk about AFib in more detail, but just a brief run through. The pacemaker just in someone's hand to kind of give you an idea of what it looks like for a size comparison. This is a defibrillator, which every defibrillator is a pacemaker, but a defibrillator has the ability to shock the heart internally if you're predisposed to having abnormal heart rhythms. And there are these things called wireless pacemakers. These historically pacemakers have been implanted in the chest using a vein that goes down into the heart to get the wires into the heart. But now we have these new pacemakers that for specific situations can be implanted directly in the heart, usually around here. And they don't have all the wires and things that go across the chest. So anyway, pacemaker technology has really changed quite considerably over the past few decades, in particular with these wireless pacemakers and with the size and battery capacity of these defibrillators. So they become smaller and smaller and less invasive, although it is an invasive procedure to put these in. So So that's a slow heart rate. What's a fast heart rate? Tachycardia. The things that can be really concerning that I'm highlighting here on the right side of the screen are ventricular tachycardias, or fast heartbeats from the bottom chamber of the heart. These are the ones that can be really potentially deadly, particularly in patients who've had heart failure, who've had heart attacks, they have scar tissue built up in their heart. They kind of had this feeding ground in the heart muscle that electrical circuits can kind of run wild and cause the heartbeat to go out of control and basically make the heart ineffective. And a lot of times this is the dramatic thing that you see on shows like ER, or some of the more updated medical shows when someone's getting, they bust out the paddles and shock someone back to life. It's typically because they're suffering from VT or some really bad heart rhythm from the bottom chamber of the heart. But we'll focus on, in terms of the clinical talk today and what's most prevalent, is something called atrial fibrillation, which is the most common abnormal heart rhythm that we deal with, and it comes from the top chambers of the heart. We'll go into more detail here in a second. But symptoms of arrhythmia in general, whether they're from the top or bottom chambers of the heart, they can run the whole gamut of experience. So you can feel heart palpitations, heart fluttering, chest pain, shortness of breath, fatigue, dyspnea on exertion, faintness. You can pass out. All these things can be signs that you might be having an arrhythmia. Now, there's a lot of crossover between these types of symptoms and other things, not even directly related to the heart. Lung cancer, lung disease, all kinds of other issues. So all that to say, if you have any of these symptoms that are concerning to you or that are new, or you started to notice them, they're affecting your life, that's something to bring up with your doctor, whether it's your primary care doctor, your cardiologist. We're always happy to discuss these things with you and to talk about the workup and make sure we're not missing anything that we can potentially treat and help you feel better, or at a minimum help you feel better, in best case scenario prevent these and help save your life in the right situation. What are risk factors for developing arrhythmia and AFib in particular? Like what Dr. Marsden talked about, there are some things that are modifiable and non-modifiable. Age, that's, I guess we can argue whether that's a modifiable risk factor. There's all these talks about healing, fountain of youth potions and things like that, and we haven't really cracked the aging conundrum yet. But other comorbidities like hypertension, high blood pressure, high cholesterol, heart failure, sleep apnea, overweight, obesity, things like that. Smoking, alcohol, smoking just in general, whether it's tobacco, vaping, none of these are safe either for your lungs or for your heart, despite the popular appeal that vaping is maybe a healthy or healthier alternative to classic kind of tobacco, cigarette, cigar use. That's really not the case, unfortunately. And alcohol use, I'm not a Puritan here, so I'm not going to say that you should never drink alcohol. But in certain folks, even a sip of red wine can be a very potent trigger for AFib or other heart rhythm issues. Or in general, of course, if you drink to excess or if you drink too much or above the recommended daily amounts, it can increase your risk of cardiovascular disease in general and arrhythmia in particular. And chronic lung disease, stress, anxiety can certainly contribute. Coffee is always a big question that we get in clinic. Doc, is the coffee that I'm drinking increasing my risk of an abnormal heart rhythm? I've actually got some good news for you. On a population level, the people who drink coffee versus non-coffee drinkers, coffee drinkers are not at any higher risk compared to non-coffee drinkers of developing arrhythmia. It's not to say that for an individual patient, this is on a population level. For an individual patient, coffee can be a trigger for fast heartbeats or irregular heartbeats, and it could be dose dependent too. So instead of drinking a gallon of coffee a day, maybe just 1 or 2 cups and you'll be just fine. But all that to say that coffee in general is not a big instigator of abnormal heart rhythm. So you can have your cup of coffee if you want it.
What about other things that have a huge amount of caffeine, like what do you call those, energy?
Like the Monster energy drinks and 5-Hour Energies, yes, those are, because they're a lot of times they have caffeine. The reason why they're energy drinks is because they have high doses of caffeine in them. So drinking one of those might be equivalent to 5 cups of coffee or more. So that's in a potent dose like that. Those tend to be a little bit more. I'd be more cautious using those on a regular basis, certainly. I would, in general, I would not recommend using those, especially if you have any history of heart disease or personal risk of arrhythmia. So how do we diagnose these things? This is kind of they're a little bit more subtle now, but this is just to prove a point. When you come in the clinic, we undress you, we take your shirt off, we put these goofy wires on, and we get that 12-lead EKG that I showed you. And this is what you'll see if you come into a cardiologist's office or many doctors' offices. But things have changed a lot. These things are all readily available. A lot of you might have an Apple Watch on that you're wearing today, have some other type of wearable heart monitor, Fitbits, these rings that are coming out, these Cardia monitors that you can put your fingers on. So all that to say is that never before in history has an individual patient had more power to help at least diagnose some of these issues that might be going on. Now there's good and bad with that. Some of these cause more anxiety than what they're worth in some people. Depending on what they show you, the monitor can show some noise, and it's not really a concerning heart rhythm issue. That's up to us to help decide, help you kind of decipher that and determine what's safe and what's not. But all that to say, we have more power, and by we I mean we as a population, not just doctors. You as patients have more power than ever before to diagnose some of these issues and to bring them to your doctor's attention. At least even if they're benign or not concerning, at least you can have a doctor review it to make sure that it's not anything concerning. Or if God forbid it is an abnormal heart rhythm, that we can get you on the right track to make sure we're taking good care of you. And this person actually, their AFib or their Apple Watch actually alerted them to their diagnosis of atrial fibrillation, and that's something that's not uncommon. We see that all the time. Multiple times a week, someone gets grandma gets their Apple Watch for her birthday, and within a week or two, she's got an alert that she's got an abnormal heart rhythm. And what do we do about that? So that's a big question now. And that brings me to the topic at hand. We kind of went through the whirlwind of what is arrhythmia in general. And now what is the most common arrhythmia that we deal with? And that's atrial fibrillation. We went over on the left side here. This is the normal conduction system that I mentioned. A nice, beautiful EKG that's nice and normal and pristine. As opposed to AFib, instead of these impulses coming from your normal pacemaker, the pacemaker is kind of drowned out by all this chaos, this just complete and utter chaos in the atrium. That thankfully we have this AV node that filters a lot of the chaos. So, in AFib, the top chambers of the heart can be going as fast as 300 beats per minute. You don't feel that, thankfully, because this AV node is a really good gatekeeper. And instead of feeling 300 beats a minute, you might feel 100, 120, 160 beats per minute. So it filters at least half of those impulses down to the heart. Now, there are some special circumstances where the AV node can't filter that, and the heartbeat goes really fast, and that could be a potentially deadly situation. That's something that we would like to obviously address. But in general, AFib is just a chaotic heart rhythm, and this is kind of what it looks like on an EKG. This baseline, instead of being nice and smooth and with these discrete signals, it's just kind of all irregular. It's chaotic. There's no rhythm to it, and then these heartbeats can kind of intermittently sneak through that gatekeeper there and cause the irregular heartbeats, cause the symptoms that I just spoke to you about, the palpitations, the shortness of breath, the fatigue, the weakness. And some stats on AFib, we could spend an hour just talking about AFib stats, but these are some of the most interesting ones from the most recent guidelines that were published in 2023 through the American College of Cardiology and the Heart Rhythm Society. So as we mentioned, it's the most common sustained arrhythmia globally. Almost 5% of adults in the U.S. have it. It's approaching 11 million. As of a few years ago, it's probably closer to 12 million now, or closer to 11 million now. Individuals with AFib, in terms of the cost that individual patient spends, so to speak, in the healthcare community compared to someone without AFib, it's almost 2 or 3 times more costly to have AFib as far as the dollar cost goes. $28.4 billion is spent per year in either direct or indirect costs from AFib. 12.1 million people are expected to have it in the U.S. by the year 2030, and with an incidence of 2.6 million per year by 2030. So that's in 5 years. It's crazy. It's really not a big, we'll go over, I'll show you a map in terms of the breakdown by race and ethnicity and geography. But more importantly, morbidity and mortality. If left untreated, you are 1.5 to 2 times more risk of dying in any given time period if you have AFib. Not necessarily from AFib, just with all the comorbidities that come with it. You're at 2.5 times risk of having a stroke if left untreated on average. And even more importantly, you might not have a full-blown stroke, but if left untreated, you're at really higher risk, 1.5 to 2 times more likely to have early dementia, early cognitive decline, memory issues, things that we could prevent if we're aggressive with treating this abnormal heart rhythm. And in men in particular, depending on which study you look at and which population, It's a bit more prevalent in men versus women, 10.3 versus 7.4%. The Framingham Heart Study, which is a cohort study that was done in a town outside of Boston, Massachusetts. At age 60, that cohort of men, 26% of them had atrial fibrillation by the time they were 60 years old, so 1 in 4 men. We had a similar in Bogalusa. There was a big Bogalusa heart study. It's kind of similar to the Framingham study. I think the stats are pretty similar as well, if not a little bit higher. And then the incidence here, in men versus women, men are 2 to 3 times more likely, per 1,000 person years to develop AFib compared to women. So it's something that we see more commonly in men. It's not, plenty of women have AFib too, and we treat it very similarly. But we need to be a little bit more attuned to it given the higher prevalence and higher incidence in our male population. And these are the stats I was mentioning just about race and ethnicity. It's interesting to see that kind of these East Asian, Russian, China, Mongolia, Middle Eastern countries have a high prevalence. Greenland has a high prevalence. And then, of course, here in the United States, we'll show you this picture. Here you can overlay this map with any type of comorbidity, diabetes, high blood pressure, stroke. And this is just for age 65 years old, the rate of AFib hospitalizations from 2019 to 2014 is really high in our locality here. So it's something that we need to address, and we're starting to I guess realize the importance of it. We've realized the importance of it for a while, but starting to address it deliberately, not just with things that we can do as physicians, but things that we can do as a society and as a community to help treat our patients with atrial fibrillation. Now this is a ripoff from the 2023 guidelines of AFib. This is kind of where the doctors come in. It's kind of a Greek motif here. We've got pillars, we've got a foundation. The doctors come in to handle the pillars of treatment. So stroke risk, we'll talk about that. Optimizing your risk factors, we'll talk about that. And then symptom management of AFib, either with medicines or procedures that we can do. But what I want to draw your attention to with this slide, and they put this on the foundation for a reason, because without the foundation, there's almost no point in trying to build the columns on top of it if you're building it on a foundation of sand, so to speak. So you really want a strong foundation of treating your risk factors. And what are those? That's treating heart failure. If you're smoking, to try to talk about smoking cessation, regular exercise, weight loss, alcohol, either cessation or moderation, depending on how much you drink. If you have high blood pressure, if you have diabetes, and sleep. I want to focus on sleep a little bit. Sleep regulation, getting your 7-8 hours of sleep a night is very important. But also, considering if you have any type of sleep apnea, snoring, and if your loved one, whoever you're with at night, notices that you're going apneic, or you're not breathing in the middle of the night, it could be a sign that you have sleep apnea that's undiagnosed. And you need a sleep study for that, and consider therapy, like mask ventilation, things to help treat the sleep apnea and help prevent some of these episodes, these arrhythmia episodes from happening. So that's why I bring your attention to the foundation, because it's really important. Without this, a lot of times the medicines or the different modalities that we use to treat the underlying arrhythmia, it's hard to treat it successfully if we don't also take care of the other comorbidities. This is all in the setting of shared decision making too. We're having a constant conversation with patients to make sure we're all on the same page, that we're in agreement. We talk about options, and we talk about the best way to go forward. So stroke. What's the most important thing that any patient has in AFib? Anytime that I see someone in clinic, especially in the first meeting and certainly going forward, we talk about stroke risk. Anytime someone has atrial fibrillation, that chaos that I mentioned in the top chambers of the heart, because the heart is not beating very efficiently, these top chambers are just quivering, and instead of sending the blood up and down through the valve here, the blood is just kind of pooling up, and it can pool up in a place called the left atrial appendage. And when blood pools up, it clots off, and when it clots off, it can break off and go to the brain or other parts of the body and cause something like a stroke. So what do we do to prevent that? The mainstay in therapy is oral anticoagulation. The most common ones that we use are apixaban or Eliquis, and then rivaroxaban or Xarelto. These are other medicines that are also available. But Eliquis and Xarelto are two of the most common medicines that we use to treat or prevent strokes in patients with AFib. We grade your risk of stroke based off your comorbidities. So if you have heart failure, it's something called a CHADS-VASc score. If you're more than 65 years old, if you've had prior heart attacks, if you've had prior stroke, if you have heart failure, if you have hypertension, if you have diabetes, these all kind of add up to increase your risk of stroke, anywhere from a 2 to 7 or even 9% risk of stroke per year without a blood thinner. And that's an unacceptably high risk. And with the blood thinner in your system, we get that back down to just the average risk of having a stroke just by being a human walking on the face of the earth. So we hope to get that back down. So that's, if you or a loved one or anyone has AFib, or you think you have AFib, one of the big reasons to think about it and be concerned about it is, am I at risk of having a stroke, and do I need to talk to my doctor about being on a blood thinner? Because that's one of the conversations that I have constantly with patients, and I try to get them to prevent a big stroke from happening. Patients who are not a candidate for blood thinners or have excessively high bleeding risk, there is a procedure to kind of plug off that area in the heart called the left atrial appendage that I mentioned that's responsible for a lot of the strokes in AFib. Yes, it's something called a Watchman device, or this one's called an amulet. There are a few different commercially available devices. We do these procedures here at Our Lady of the Lake, and I do the procedures as well. So they are available. It's something that you can discuss with your doctors. But in particular, the mainstay of therapy is still a blood thinner, however. But if for some reason you're not a candidate for it, or there's some concern, there is an option to potentially get you off a blood thinner in the future. But that's a very in-depth conversation that you need to have with your physician. And then the last kind of big thing I'll mention is catheter ablation of atrial fibrillation. The way we've treated AFib historically is we've diagnosed it, we get people on a blood thinner to help treat the stroke risk. And we talk about medicines to at least control the heart rate while in AFib. But what do we do about controlling the rhythm itself? And we know that our hearts like being in normal rhythm. Our hearts like being in sinus rhythm. That's the normal rhythm of the heart. The more our heart is in AFib, the more the heart remodels in response to that, and the more likely it is that AFib begets more AFib. So the earlier we diagnose it, the earlier we treat it, either with medicines to control the heart rhythm or with catheter ablation, the better it is in the long run. And this is data proven, this is scientifically proven, with early rhythm control that we help prevent a lot of the morbidity and even mortality in some people, depending on the patient population with AFib, particularly if they have heart failure. So how do we treat it with ablation, which is a minimally invasive procedure? We go in through a blood vessel in the leg here called the femoral vein. We get our catheters inside the heart. The part of the heart where the AFib comes from, the top left chamber where the pulmonary veins plug in, we do something called an ablation, where historically we've used heat or freezing, cauterization or freezing technology to kind of destroy the tissue that's responsible for AFib, or at least isolate a lot of the tissue that is. The problem with that approach historically is that there is a slightly increased risk of kind of collateral damage. The heating and the freezing can kind of extend beyond the borders of the heart and can theoretically damage some other tissues around it. Now the risk of that is low, and we have very specific methods to help prevent that from happening. But there's been this advent of a new technology called pulse field ablation, which is an effective way to treat AFib, but it's also a safer way to deliver therapy that isolates the specific heart tissue and spares some of the other collateral tissue around the heart. So this is a picture of an AFib ablation with the kind of historically and still commonly used technology. So here is the right atrium, the left atrium. We've gone up here through the femoral vein. We've got our catheters inside the heart. We've crossed over to the left atrium where these pulmonary veins that I'm highlighting here kind of plug in. And that sleeve of tissue is really electrically active. And what we've done is either cauterize here with the red dots or use a freezing balloon, kind of displayed here in the light blue circles, to kind of electrically build a dam in that area. So these AFib triggers are kind of contained within this ablation, and the rest of the healthy heart is allowed to beat on its own and prevent the AFib from happening. And this is an example of the RF or heating catheter. And this is an example of the cryo balloon catheter. We typically use nitrous oxide to kind of super cool the balloon and freeze the tissue. And this is kind of looking, instead of from a front view of the heart, this is kind of looking at the heart from the back where the veins plug in. And basically what the ablation is trying to do is electrically isolate those veins and spare the rest of the heart, the rest of the healthy tissue, ideally early on in the disease course before the AFib has kind of broken out and caused the rest of the heart to just kind of scar down. We try to contain the AFib around those pulmonary veins to treat it. And what is this pulse field ablation? So this new technology, I say it's new. We've known about it for over 20 years, but it's just becoming commercially available in terms of treating patients with atrial fibrillation. So instead of burning or freezing the tissue, what the pulse field ablation does, it delivers high density electrical current that this is the cell membrane of a heart cell. And what it does is it pokes little, it's called electroporation. It pokes little holes in the heart membrane. It allows the cell contents to spill out, and that initiates something called programmed cell death that targets the specific heart tissue and tissue that are triggers for AFib, and we spare the rest of the tissue that's around the heart. These are some of the catheters that we use. These are all the different companies that they have. It's basically these silver little nodes that you see on all these different catheters are where the electrical field is delivered. We basically rotate the catheters around. We have very fancy kind of 3D mapping tools and electrical signals that we can tell where we've delivered therapy, where we want to go to make sure we're doing things safely. And this is another picture showing, this is the kind of classic RF or heating energy. This is the freezing energy. You can kind of see the esophagus here, which is behind the heart, or the phrenic nerve that controls the diaphragm or the breathing muscle. These are all susceptible to collateral damage with the freezing or the heating technology, as opposed to the pulse field ablation here that just focuses on the sleeve of heart tissue that's kind of in the light red, and it spares the other nerves for the same type of ablation approach. So what are the take-home points here? Abnormal heart rhythms are very common. They come from the top and bottom chamber of the heart. Sometimes if they're too slow, we talk about a pacemaker. Sometimes if they're too fast, we talk about medicines. We talk about ablations. We talk about different approaches to treat this. I will say, though, that one of the most important things that's overlooked and that I try to talk about with all of my patients are the foundational approaches, the treating they're getting you back exercising, smoking cessation, eating healthier, all the important things that without that foundation, we can do all the ablations, all the medicines, everything in the world, but that AFib or a lot of these heart rhythms will still come back. So it's important to treat the whole body. So it's not an either or, it's a both and type approach. We talked about the risk factors. These can lead to life-altering symptoms. If you're short of breath every day, if you feel irregular heartbeats, you can't do the things that you want to do at a minimum. And the worst case scenario is these heart rhythm issues can be potentially deadly if we don't approach them and diagnose them and treat them. And then AFib in particular, any patient who is concerned or has been diagnosed with atrial fibrillation, you need an evaluation with an EKG and even with a cardiologist to talk about your atrial fibrillation. You need to have a conversation about stroke prevention. That's the most important thing. We need to talk about a blood thinner. Are you a candidate? Is it appropriate for you? Can we do something to prevent a potentially either deadly or life-altering stroke? And then the rhythm itself. How do we prevent AFib? How do we prevent it from going from paroxysmal, which is AFib that comes and goes, to persistent AFib or permanent AFib? The trick with that is diagnosing it early and treating it either with medicines or with these catheter ablations that we have available now that are safe and effective at modulating the disease course and helping to prevent the AFib from becoming a persistent issue for you. Those are some of the references, and I thank you for your time and for being here. It's really, I've been to Pennington before. I haven't been here for the Men's Health Summit. I was really impressed by the amount of people that are here, the screening and everything that's available to you. So I appreciate you all taking ownership of your health and being here and listening to us kind of bloviate about a few things. But we're happy to answer any questions you might have, or we'll leave it up to y'all.